Welcome, everyone, to another special episode of Arthritis Consumer Experts, hashtag CR Arthritis. Today, I'm happy to be joined by Dr. Walter Maksymowych, who's a professor in the Faculty of Medicine and Dentistry at the University of Alberta. He is also a co-founder and principal investigator of the Spondyloarthritis Research Consortium of Canada, SPARCC. Dr. Maksymowych, welcome to the show.
It's a great pleasure to be here, Kelly. Thank you for inviting me.
Now, you're participating in part one of a session provocatively called On Controversies in Rheumatology that has as its focus the complexities of first-line targeted therapies for axial spondyloarthritis, which is more commonly called axial SPA. I wonder if we could start there and you can define for our audience the diseases that are captured under the name axial SPA.
The term is used to denote an umbrella of disorders which are in common in that they affect the sacroiliac joints and spine. So there is inflammation affecting these particular anatomical locations. But there are other disorders that fall underneath this umbrella that have differentiating features. So, for example, patients with psoriasis can develop a variety of joint problems, which include arthritis in the sacroiliac joints and spine. And for your listeners who might be unfamiliar with the sacroiliac joints, these are located right at the bottom of the spine, where the hips kind of connect to the spine. So that's where the sacroiliac joints are located. So psoriasis patients may experience this problem, and then patients with inflammatory bowel disease are another group of patients that are higher risk of developing arthritis in that particular location. And then there is a condition that we don't really see too much of in Canada, but is seen in some other parts of the world, and that is called reactive arthritis. This is a condition where some patients have, for example, certain bacterial type illnesses, typically illnesses that cause diarrhea, severe diarrhea. And some of those patients, shortly after having the diarrheal illness, develop inflammation in the sacroiliac joints and spine. And so these all fall underneath this umbrella term, axial spondyloarthritis.
Now, your session is titled Axial SPA. Should one use TNF inhibitors or IL-17 inhibitors or JAK inhibitors as first-line targeted therapy? Now, with so many treatment options now available, how do these advanced therapies work differently in managing axial SPA?
Yes, that's a great question. So increasingly, we have more options. I would say, first of all, that there's still not enough in view of the fact that this is a disease that can last for several decades. So three options is really still not enough. We need many more. And especially because this disease affects people in the prime of life. So these are all therapeutics that target, or if you like, neutralize certain chemicals that trigger inflammation. So, for example, tumor necrosis factor, or TNF for short, is a very important molecule that appears in the joints of patients with this condition. So you find it in the sacroiliac joints, you find it in the spine. It's not just in these conditions, it's a molecule that's one of those molecules that kind of makes you feel sick when you have the flu. You feel fatigue, you get aches and pains, you get joint stiffness. But also it's an important molecule driving inflammation in joints. And so what our biologics do, these are antibody type molecules that neutralize TNF. So when you give yourself an injection with this treatment, it will neutralize TNF and alleviate all of those symptoms, the pain, stiffness, and the fatigue. Now, we can also target other molecules. There are other molecules that bring on the same type of symptoms. A second example would be interleukin 17 or IL-17 for short. So again, we can manufacture and we have available antibodies that target this molecule. Now, some people respond better to one kind of antibody molecule, for example, blocking TNF, and other people will respond better to blocking IL-17. We can't quite predict which patients are going to respond to which type of blocking antibody. And then the third option are these JAK inhibitors. Now, JAK inhibitors are very, very different. It's spelled J-A-K, not J-A-C-K. So the JAKs are important enzymes produced in our cells. And these enzymes, it's like the cell reacting to things in the environment. It could be bacteria in the environment, or viruses in the environment. And these bacteria viruses trigger overactivity of these enzymes within the cells that we call JAKs. And what we do in arthritis, what we can see in arthritis, is these JAKs are activated. These enzymes within cells in the joints are very, very active. So we kind of want to switch them off. So there are ways of doing that with these new therapeutics called JAK inhibitors. They switch off these enzymes. And in doing so, they actually block the production of a lot of these chemicals like TNF, like IL-17, and others that bring on all of these symptoms of pain, stiffness, and fatigue, and they alleviate the inflammation. So we have these three options now, and the question is, how do we have a patient in front of us presenting with the condition and all of these symptoms and has failed simple anti-inflammatory therapeutics? Which among these three options do we choose? That's what the debate is about.
Right. And certainly our audience is familiar with the notion of personalized medicine. We've talked about it quite a bit over here at ACE. I think this is a good example where maybe you can help people understand what factors do rheumatologists consider when deciding which of these medications should be first used for a patient with axial SPA.
And that's a great question, and that's exactly what I'll be discussing.
Hmm.
Now, just as an example, one of the problems that people might have as a complication of their spondylitis is they may get an acute inflammation of the eye. That's very alarming to people. It's called uveitis or iritis. It's an inflammation of the iris. And so that presents with intense pain and a red eye, acute onset. People are afraid they're going to go blind. They head straight for the emergency department. And of course, especially if it's the first time they've experienced this. So we, of course, want to avoid that happening as a complication with spondylitis. And some of these drugs work in blocking uveitis from happening, preventing it, whilst others don't. So, for example, a TNF inhibitor, which was the first group of drugs that came out, most of these, not all, but most of these are really quite effective at preventing that eye complication. So if somebody comes to see me and they say, yes, I've already had attacks of this painful red eye, then I'm going to focus on using a TNF inhibitor as a first choice therapeutic. And if somebody, on the other hand, has psoriasis, I might choose an alternative therapeutic choice.
In terms of patients uh, being encouraged to be part of this decision-making process, one of the things I guess they need to be aware of are, what are the specific benefits or risks associated with each of these treatments, in order for them to have a really positive, constructive conversation with their rheumatologist when they're making this really important decision. Can you elaborate on that? Is that part of this session as well?
Yes, as it would be with any therapeutic,
Mm-hmm.
we take into account what we know about safety and which types of patients might be at risk of some complications of treatment. So, for example, we do know that with the JAK group of drugs, that there is evidence that people over the age of 65, especially males, and especially if they've been smoking for prolonged periods, would be at risk of certain types of complications like a blood clot. And
Mm-hmm.
so we'd be more cautious in prescribing and would veer towards one of the other therapeutics if that was the type of patient in front of us. But the information that a rheumatologist will typically capture will be aspects around the axSpA itself and what kind of complications from the axSpA that the patient has had, because we would, of course, prefer to use a therapeutic that works not only for the axSpA, but any complications that the patient might have. And then, secondly, we would also look into other medical factors, possibly family history and any risk factors, for example, for heart attacks or strokes. So, a general medical inquiry would be very important. It would be very important for the physician to know about a patient's medical history and any additional problems that they may be experiencing, because that brings then into question, well, I may select such and such a therapeutic because it's going to be safer for this particular patient.
Dr. Maksymowych, thank you very much for clarifying what is described in your session as a controversy. I think that has been really helpful for our audience, particularly those who are personally affected by this disease, to sort of clarify in their minds how these three different important treatments work and considerations for them when they're having conversations with their doctor. And ACE certainly agrees with you that there can always be more innovation in this disease area. And we hope that the next time we talk, there might be discussion about a fourth alternative.
Thank you so much, Kelly.
And thank you to our audience for joining us again for this episode of CR Arthritis. Please join us again. Thank you.